welcome to this, the fifth of the events in the Integrated Nutrition Seminar Series. Before we get going, can I say that if anybody's not on the distribution list and would like to be on the distribution list, we will have the list out on the table at the back. Please sign up so that you keep up to date on these events, which so far, by the look of things, have been really successful. Okay, as always, I'd like to start by acknowledging the traditional owners of the land on which we're meeting today, the Gadigal people of the Eora Nation. And then I'd like to briefly introduce my co-chair for today's session, Dr. Juliet Bennett. Juliet is a postdoctoral researcher in the sociology of food, working on a joint program between CPC and the Sydney Centre for Healthy Societies, which is based in the School of Sociology and Political Sciences. She's working with myself, with Alex Broom, and Katie Kenny, apologies. Okay, and Juliet's a member of the TIMS EMCR team, so she's going to be organising the discussion, chairing the discussion period. Next, last but not least, I want to introduce our speaker for today, Tim Gill. Tim's director of the Obesity Collective and senior research and program development advisor within Sydney Local Health District. He's also an honorary professor in public health nutrition in the Charles Perkins Centre at the University of Sydney. Tim has wide experience as an academic and within government departments and health agencies, and has authored over 150 academic papers and book chapters, together with several key reports and scientific papers on nutrition, obesity, and chronic disease. So Tim is a really valuable member of our group in Charles Perkins Centre, with experience both in the academic and the more applied aspects of health sciences. Tim's particular interest is in improving community and consumer engagement in research, health service planning, and public health policy. And today he's going to speak to us about community engagement in nutrition and obesity research, with some support from Andrew Wilson, who's also here today. So I'll hand over to you.
Great. Thanks for that, David. It's nice to be back here at the Charles Perkins Centre to deliver this talk. A couple of disclaimers before I start. First of all, I don't pretend to be an expert in this area. In fact, it's really only become a recent interest of mine since beginning working at the Obesity Collective and coming to understand a lot more through my interactions with people like Andrew about the importance of effective consumer community engagement as an appropriate, not only appropriate, but a really important, useful aspect of developing and implementing research. So I'm going to use Andrew during the presentation. I'm going to try and work through the formal part of the lecture and bring Andrew up so that we can have a bit of two-way discussion and then engage with any questions you have about lived experience perspective. Somebody who's been involved in research, been engaged into research, but also has been involved in the consultation process about research. So I'm going to start with a little quiz for people. Don't have to put your hands up because that will probably only reflect whose PhD student you are, whose group you work in. But I was to ask you, who has the most expertise around nutrition and what we should eat? We have a lot of great experts here at CPC. So, obviously Luigi is a good example. I mean, runs a clinic on this thing. He has a lot of research projects around longevity and issues like that. But then, of course, we've got Steve, international expert. We've got David, who has some really great research around this issue and, profound changes in this. We've got Margaret, who spent a lot of time dealing with these issues her whole career. Which one of these would be the expert? Or is it Kylie Jenner? I'm sure it's a lot to say on that. So perhaps she should be the person we listen to. But what about obesity? Because of course that's also where we have expertise within Charles Perkins Centre. We have some of the world's experts. Louise Bauer, definitely world expert, particularly if you're dealing with child or adolescent nutrition. We should really be listening to her. David, David James, again, international expert around obesity issues. Samantha Hocking, certainly coming forward in clinical management of obesity. Nick Feiner, has a lot of issues on these things, or perhaps somebody outside like Claire Collins, who works at Charles Perkins Centre as well. Are these the people we should be listening to when we're designing our research and getting our research questions profound? What about when we're dealing with First Nation issues? We have the Posh Institute here. They are experts in Indigenous nutrition. We've got Jackie Choi's our leader here in nutrition. We also got Tim, who does a lot of work with Indigenous communities in remote areas. So we've got all this expertise in the Charles Perkins Centre. We don't need anybody else. We've got everything here, haven't we? Well, the problem is that these people are not the experts in what the community eats or should eat, or how it eats, or how it undertakes, what it thinks about food. The real experts are the people themselves, the community. If you want to know about Western Sydney, you go to Western Sydney. You don't get your answers here. You don't get your questions here. You don't get a good understanding of what's happening, what are the problems, what are the real issues. You speak to the people in Western Sydney. If you want to know about what obesity is really like, what it's like living with obesity, what sort of questions are important to answer in terms of improving the management of obesity, you need to deal with people living with obesity. And the same with our First Nations communities. We need to engage them. If we don't, then we risk not getting the right research questions and thus the right answers to that research. Unfortunately, we've had a bad history in academia of dismissing the understandings and perceptions of the community and of consumers. We treat them as somehow being ignorant, as not understanding. There are thousands of these sorts of studies that look at the level of consumer knowledge around this and that. And of course, consumers can't repeat back exactly what the dietary guidelines say. They don't know what the role of vitamin D3 is. They don't know these sorts of things. That doesn't mean they're not experts. Just means they don't work within the same frame that we do. And that's a bloody good thing, because clearly we're not doing terribly well. And the big issue, the big problem with this is that, and one of the reasons why the Charles Perkins Centre was formed was this ongoing research practice gap. So there's some, well sort of quoted figures about only 14% of clinical research findings being translated into practice. And on average, it takes 17 years for a research finding to actually get into practice. Now that comes from, as you can see, a paper from 2000, was a fairly small analysis, but it does highlight the challenges we face. And clearly, if we want to overcome this, we've got to start thinking a bit differently, and we've got to start acting a bit differently. And that's exactly where this notion of better community consumer engagement or involvement comes in. So quickly, I just want to go through why it matters, the key definitions we're talking about, the frameworks and approaches, because there's a lot of information out there. There's a lot of people doing this work. There's a lot of issues going on. And as I said at the start, I don't pretend to be the expert. In fact, the reason I'm standing here speaking to you is that it's only come to me very late in my career that this is an important issue. I also understand that in research, in preparing research grants, in getting research ideas up, there's a lot of stresses and issues and times and aspects. And a lot of these things appear to be unnecessary burdens on you, ethics applications. Geez, when I did my PhD, nothing
Yes,
went
yay.
through. Nothing went through.
The old days.
I was taking blood out of people, nothing.
Sorts of things.
When we went to euthanize rats, we banged them on the bench, their heads on the bench. That's how, how much progress we've had. But still, in a lot of issues, we haven't really got down to better use of people with lived experience of issues. So I want to do that, give a few case examples, and particularly then talk to Andrew about his experiences, because I think that's going to be more illuminating than anything I can say. So why engage with communities and consumers? Well, we all know funders and institutions require it. It's been probably 15 years now since National Health and Medical Research Council have required consumer engagement. Doesn't mean that we've been doing it terribly well, but it's their learning requirement. But if that's the only reason that we get into this, then we're going down the wrong path. We're doing it for the wrong reasons, and ultimately we're not going to improve our research, because there are an enormous range of other benefits for your research, particularly in terms of getting relevance. The people who have the problems know the problem. They're much better positioned to give you an idea of what needs to be answered. We need to improve our recruitment. I'll come back to that later on. We get better design of data collection tools. And I'll talk about that a bit later on. We help manage expectations, and also by involving the community or people with lived experience into your research, you get better dissemination of it through their networks. If they're involved in it, engaged in the process, they talk about it, they explain it, they get the information out much better than you can. And that's where college journey comes in. And then you be able to build trust and legitimacy around the issue. And as I said, support implementation and ethical obligations. Right. So not everybody evaluates the impact of consumer and community engagement, but it is becoming now a much more important feature of research reports. And very soon journals are going to actually require you to demonstrate that you're doing this and where you did it and how you did it. So this was just a systematic review, and I think there was about over 134 publications they identified that had specifically evaluated the impact of their engagement and explained their engagement and using a particular tool that was developed. And so they're able to determine what was the impacts of that engagement. And what they found was, of course, there was much better representative samples of participants. There was a lot of much better research relevance to the consumer themselves. They felt that this research was tackling an issue they did. There's a lot more empowerment, respect, confidence, satisfaction, increased knowledge, better engagement of participants, better recruitment, better interpretation, and that ultimately led to more funding opportunities and a better way of demonstrating impact, which you're all being asked to do now as well when you apply for your grants. So lots of benefits. Just quickly, when we're talking about this issue, what do we mean by community and consumer? Well, they're pretty open-ended sort of definitions. This community is not just sort of a geography, but it encompasses shared identity, issues, actions, those sorts of things. And when we talk about consumer, we talk about a person with lived experience, basically, the people that we're trying to help by doing this research. That's our motivation for research, or should be our motivation for research. And engagement is a really important term because it talks about active involvement. So when you read the documents, there's a lot of discussion about community and consumer involvement. But I think if we really want to get to the real achievements and benefits of this process, then we have to think about engagement, active engagement, rather than just involvement. So in Australia, we talk about CCI, consumer and community involvement. In other parts of the world, they talk about PPE, patient and public engagement. Same sort of process, different things. Right. So when we look at the Australian population, you've got to admit it's a pretty diverse group. Most populations are, but Australia probably even more so. There's a whole line array of age, whole range of ages, genders. There's culturally and linguistically diverse groups, people coming from around the world and different things. So, you know, about half the Australian, more than half the Australian population were born overseas, or their parents were born overseas. 30% of them have come directly to Australia. We don't just have people living in major cities, we have people in regional, rural areas and very remote areas. And we have a particular community called First Nations populations, which have special needs. So this diversity presents a lot of challenges in terms of research. It's almost impossible to capture all that diversity when you're trying to find your participants. But we shouldn't see it as a limitation. We should see it as a real challenge and an opportunity, because there's lots of issues that arise because of that diversity. Unfortunately, when we look at recruitment, because we don't think about engaging very early with communities and consumers, we tend to end up grabbing whoever we can to be participants. And I know I'm not trying to be critical here, and I know a lot of studies are, you know, short-term, small, and they involve, you know, student projects and things like that. But a lot of recruitment seems to occur within the university population itself. And I don't think that's very diverse. I don't think that's really capturing the theme of the Australian population. So I'm not trying to lecture, that's, you know, as I go on later on, I'll show you how poor I am. So what is engagement? What does it mean? Well, it has to be more than just tokenism. It's not just filling in a form, putting it into a grant application. Inclusivity. Oh yeah, that's, yeah, right spelling. So it has to be inclusive. It talks about collaboration. And whilst it does involve providing information, it needs to go beyond just that. So there needs to be this two-way communication, and it needs to be understood that what we're trying to do here is generate solutions. That's the whole focus of involving other people, not just a process to tick boxes. And it must involve giving up some of our own power to empower those partners that we bring in. The community representatives, the consumers, the patients, the lived experience people that we bring in. Right. So there are obviously various levels of engagement that you can undertake. And the level of engagement you would go to with a particular research project will depend on the nature and style, length, in, you know, the funding, you know, a whole range of factors. That doesn't mean that we need to go to the top level always. But we should always be trying to achieve the highest level of engagement possible. So the minimum level is you're making sure our community consumers are informed about what we're doing, why we're doing, how we're doing it, and why we're recruiting them. That's the very minimum. It would be preferable to go well beyond that though. And there are a lot more benefits. The higher you go up, the more benefits there are. So if you're consulting, then you're actually involving the participants or a lived experience or a community representative group in discussions around what you're trying to achieve, how you're trying to achieve, what might be better. If you want to involve them, then they actually have a role in terms of deciding what you do. They actually have influence over what tools you use, how you collect it, where you collect data, how long things are, that sort of thing. And then when you go to the collaboration level, then they're actually partners in the project. They're equal partners in the project. You're actually allowing them to actually dictate some of the issues. And at the highest level, then you're actually transferring some of the decision-making process over to the community and consumer groups. And that is challenging. But it has potential, it's worthwhile. So when do you engage lived experience people or the community or consumers? Well, the usual stage is when you're writing the grant and you think, oh shit, we need to involve a consumer here because it's demanded of us. So all the ideas are done, all the processes there, you've already spent the budget and you decide, oh, we need somebody to come in and do that consultation for us so that we can get the ticks on the box. Exactly what I did. Not you know, pulling scorn on that. That's just the nature of academics who are hard pressed trying to find research opportunities amongst a whole range of other things, desperate to get funding, multiple research grant applications, that sort of thing. But if we really want to make the benefits of this and improve the quality of our research and get better, more sustained research programs, then we've got to start thinking a lot earlier. And so at the very earliest stages, when you're even thinking about what you're going to be doing, you should be engaging with people who have some questions themselves, have some issues themselves they want to address. And you think, well, how can these lived experience people or the community help me design my study? You'd be surprised. There are lots of issues about participating in research that you perhaps don't even think about that will impact the quality of the data that you collect, that will impact on how much data you collect and how many participants you retain. And then in the data collection, analysis, dissemination, and even down to translation, there's opportunities for involving, improving, and dealing with the concerns of those from the community. And at each stage, there's the opportunity to go to a different level of engagement that I talked about before. So even at the design stage, you can go right up to level of empowerment. You can go right up to level where you actually hand over some of that power to the community. It's not just at the design or the implementation or the dissemination stage. There's opportunities to go wherever, and it will vary depending upon, as I said, the way the project is designed, where it goes, how much funding you have, the size of it, those sorts of things. So how do we start to engage people into this process? Well, the first thing is we need to do it in a way which demonstrates that we're coming from a position of mutual respect and shared power. It's not us, the experts, you, the fodder that we need to develop and run and achieve our research aims. There needs to be an understanding and mutual respect and the willingness to share a bit of power. Really challenging. As I said, if we want to include them, then it's not much good just going to the easiest sample that we can find. We need to be concerned about diversity. In every issue, there's going to be a wide range of stakeholders, and they could contribute valuable information, valuable opinions, valuable insights that can be used to you. We need to be honest and transparent and accountable in the way we do things. So it's not a matter of saying, we just tell you what you need to know. We need to demonstrate to them that this is, you know, in this trust, we're including you. We're being transparent. This is the way things are. This is where it's going to go. This is what we hope to achieve. This is where it goes. At the same time, we've got to understand that they're not experts in the research process. They don't understand. In fact, most of them wouldn't know that you apply for research and then you've got to wait 12 months before you get a grant anyway. So there's lots of things where there needs to be some capacity building as well. We need to be prepared, if we want to get the best level of input, to spend some time sharing our skills and understandings about things with the community or the lived experience people we want to engage with. And we need to continue this. It's not one of these one-off sort of things. So yes, a lot of our research projects go nowhere, but generally, if we've got a research question, if we're dealing with issues, we're dealing with chronic disease prevention or even drug treatment, then we've got a program of research. We need to sustain that. To sustain that, we need to sustain our relationships with the community and consumer groups that we're dealing with. A lot of work, a lot of effort. There are a lot of frameworks that will provide guidance on this. We do have our own National Health and Medical Research Council Consumer Engagement Guidelines. They're very broad. They talk in principles. Some of the others, particularly the UK one and the US ones, they have more specific recommendations about exactly how you should do things. Don't have time or the expertise to go through and explain the various aspects of it. But it is interesting that a number of other research institutes actually have developed their own frameworks. And this one from SAMRE, they spent a lot of time setting this up, and it comes with not just a framework, but with an infrastructure to help researchers within SAMRE actually engage appropriately and effectively. And perhaps that's something CPC could actually consider. And not just SAMRE, I know that there are other institutes, particularly in Monash and other places like that, that also follow this. The other thing that there are is that there are lots of tools out there. And what I found is that I thought, oh my God, this is, you know, no one seems to be doing this well. There's nothing in there. There's nothing to help me. No, there is. There's lots of it. I was really surprised once I started to reflect on it and try and work out how to do things better. There's lots of tools, handbooks, information for you to draw on. This one is a particularly good one, which is from Research Translation Networks in South Australia and Western Australia. It's full of great, easy tools about, you know, how to engage people, how to evaluate, how to work on improving methodology, all sorts of things. So this is probably covered this off pretty well. This is taken from that particular handbook that I just showed you there, that you know, there are phases in which you start thinking about consumer engagement. You need really to start thinking about what we're trying to achieve, what questions we're trying to ask, and how we can involve consumers and the community in that process. And once we work out what questions we've asked, what sort of issues we want to address, then you've got to start building relationships. And this is probably the longest stage of this process, to try and get effective relationships. If you're going to be dealing with improving nutrition in cold communities, or in a particular community, or in a low SES area, or even just in diabetics or people living with obesity, people living with diabetes and people living with obesity, then you've got to invest in building those relationships. And of course, that's not going to be able to be done very early in your career. That's something that comes over the time. So if you're talking about a research career, you're talking about getting invested into these sorts of areas, spending some time in actually engaging with the sort of people who you feel at some point are going to contribute to your work. And that includes not just those community and lived experience people, but also some of the NGOs, some of the government departments, some of the other stakeholders that also will define or help you better define your research in some way. And then we've got the co-design, the implementation, and as I said, the evaluation and sustainment. And the reason why every stage of that research process benefits from a level of involvement with consumers and the community is that the research process is all about questions. It's all about developing, improving, refining, building on questions. Every time you go to the next stage, you've still got questions. You've got more and more questions. And that's where you need the help of other people to help you refine those questions, not just answer them, but get the best questions as well. All right, so I won't take time because I want Andrew to come up. So just to demonstrate some of these things, I just want to show you some case studies. And I'm going to start with some examples of my failures. So about quite a while ago now, I was involved in a project, Pacific Obesity Prevention and Communities Project. Wasn't my project, but I was involved in some of the community consultation around this thing. So this is a really big study, had a lot of funding, and it had some really good objectives. And we were involved, it did have a very participatory approach, and I was involved in one aspect of it in terms of going to certain countries and helping with the community consultation and design of some of the interventions. So I'll show you one particular community consultation that we had. And we went into, this is appalling because we didn't build, this project was based on relationships that other people had built, which is very helpful. So there were a number of people from the Pacific countries themselves who were involved in this project. There was WHO people, there were South Pacific community people, that sort of thing. So we went into these communities with views based on speaking to these people about what we should be doing. But we thought we needed to get community sort of feedback and reinforcement of our views more than anything. That's why we went in there. We thought we're going to get feedback to enable us. So in this particular case, we're looking at factors that the community felt influenced their consumption of fruit and vegetables, because one of the aspects was improving fruit and vegetable consumption. So we went through, did all, and some of the usual issues come up, and these are the things that had been sort of planned to be integrated into this project. But at the end of the day, the factor that came out top in the community's concerns and issues they felt need to be served had nothing to do with, nutrition or program interventions, or even some of the legislative or trade issues that Anne-Marie's going to be talking about. These are the sorts of things we thought. Their big concern was the market itself. The fruit and vegetable market was out in the open air. It had no covering. The food would come in the morning, very hot, be wilted by midday, wasn't worth buying. So their big concern wasn't anything about, understanding knowledge, prices, trade issues, those sorts of things. The big concern was a functioning market. And they weren't concerned, they weren't interested in anything else being done until that had been fixed. So our poor level of engagement almost led to a disaster in terms of what could be done. And so that issue had to be addressed before this project could run. So not very good on our point. The other thing was a student to look at after a clinical trial that we done. In fact, it was a couple of clinical trials. So go and speak to participants in clinical trials. And this is because we had no engagement before. We just had engagement afterwards. And sort of looking at what their experiences were and where we could improve. So it was an evaluation of it. And I was actually a little bit shocked by the fact that we just hadn't thought through what we were asking these people to do. And some of the things that we take as standard sort of practice, best practice, are irritants to them. They don't like being recruited during consultation. They've come there to be treated, not to participate in research. They didn't like some of the language in the participant information sheets. They didn't like being given a questionnaire and told they had to fill it out there and then, particularly dietary questionnaires. But, I can't remember what I had yesterday or whatever, long questionnaires about eating, that sort of thing. Didn't like the fact that they were just told when the follow-up was going to be, they'll have to come back in 3 months at this time to do this. They didn't like being told, sold the trial on the basis there's a high-level intervention, but then they weren't told that they could go into a control group. Yes, it's in the patient information sheet, but it wasn't, it wasn't what they were sold on. They didn't like things just being taken, their information being taken from trials. Didn't like measurements being taken in public area. And some of the questions that were being asked were actually quite triggering for them. So very bad. Thankfully, a lot of these lessons have been learned, and there is now good guidance about how to involve consumers in development of clinical trials. And as a result, we've got these toolkits. And I know a good example, a trial in Western Australia has been consulting with the community about how they can recruit more men, because it's very hard to get men into weight loss trials, apparently. A group in Monash are dealing with what are the concerns of the community about GLP-1 agonists. Before they run a trial, they want to know what their concerns are so they can include data collection around some of those issues. So there are simple things to be done, improved, and they're actually captured in this here. Look, I do have some other ones. Obviously, the best examples come out of a lot of the First Nations community projects. Very long-term engagement. So these people from Menzies School of Health Research in Darwin, they've been dealing with these communities for 20 years to get to a point of dealing with it. I don't have time to go through it. Same with when you're dealing with cold communities. You just don't go in. In this project, they had an 18-month period beforehand just to engage with the community to find out what would be acceptable as an intervention. Of course, people say, well, yes, this works. This is important in community-based interventions. This is really an issue, but I work in basic and preclinical sciences. No relevance to me at all. Well, it's not necessarily the case. As I pointed out before with that study in Monash, there's a whole lot of issues that people who are in basic research can benefit from by consulting with the people who they hope this research will ultimately benefit in the future. And in terms of getting more relevant research, but also in terms of being able to get people understanding and engaged in that research, supporting that research, and participating and being retained in trials because they understand what it's all about. Right. So the biggest challenges, obviously, is time. Time is a big issue. Resource is a big issue because we don't get funded. As I said, you apply for a grant, you have to wait 12 months before you get funding. So you can obviously build it in, but there's a lot of consultation that needs to occur before, and that's something that needs to be addressed. But I do want to get, because I'm running out of time, I do want to get Andrew up. Come up, Andrew. Just to talk about some of his experiences, both being a participant in trials themselves, but also, more importantly, participating in consultation processes about living with obesity and some of the trials around obesity. So I know that you have been often engaged in consultation processes by a whole range of stakeholders, by New South Wales Health, by individual research groups, even by those preparing guidelines and issues like that. So what have you found to be some of the frustrations of those consultation processes, which are there supposedly to engage somebody with lived experience like yourself?
Okay, I'll just quickly say, Tim, may take you a while to get to this stage of understanding, but Tim has a lot of respect from our lived experience people, just because he does have that understanding and that compassion and that empathy. So just want to say that straight away. Very happy to be here to support what you're doing. And, you know, when I came about 5 or 6 years into being engaged in this kind of research dealing with obesity, I was quite stigmatized myself. And I think with bigger people, particularly with obesity, you're going to come people who are stigmatized and may have some kind of trauma. So you've got to approach it from that angle and have that understanding. And they may, and when I entered that stage, I was kind of thinking, is it just me? I've just done it this to myself. So why am I even here? Like I should just be grateful that I'm even being asked, and I should go along with whatever's said, really. That was kind of how I felt. But being part of groups and the relationship, having relationship with people who understand, comes a certain level of empowerment and knowledge. So then I felt I could actually be objective and actually not objective, actually talk about this seriously, this subject, and not feel so ashamed about it. So that's the first kind of obstacle. But then there's other things too. One that Tim mentioned was a power imbalance as well. That can be definitely across research. And just to try and reduce that power imbalance, just knowing that that person has a right to be there, has a right to have these issues, and we're going to try and explore and find some solutions. Also found given a survey and just been asked to answer that in a particular sitting. You know, a lot of people in our group with obesity, there's a lot of neurodiversity in there too. So you want to give people a few different options to be able to not just sit down and make all those answer those questions immediately. Give them a bit of time. It's got to be a bit of time, a bit of warning. Also, I noticed in these groups there's not much diversity. So if we want an effective solution for a lot of people, it's not just people who can afford to be there or have the time to be there, because you're going to get one particular cohort. We need something to be broad. We need to have diversity of people who can't afford to be there, people who are hard to recruit, you know.
And so when you go to these consultations around research projects, how many lived experience people are usually?
That's imbalanced as well. It's usually you've got very few lived experience people in the past, and so that's another part of that power dynamic, is that if there's all these academics there and there's a few people who are stigmatized with potentially obesity, that's another level of them thinking, I better go on. What do they want me to say? What should I say? What are they thinking? Rather than what I think is a genuine need for my group, myself.
And when you're asked to go along to these sorts of consultations, where are they normally, and who organises them, and what sort of role you have in playing in organising them?
Well, for somebody in a bigger body, and I just say I was a lot bigger than this, so I'm a big individual, but I was a lot bigger than this. And I just remembering trying to get to places like even to an obesity clinic, but to get to a research place, you've got to overcome, you know, just some physical limitations of being in a lot of pain, generally being that size, overcoming transport. If you have to go public transport, how are you going to get there? How are you going to feel on that trip? Like you're going to feel, you know, you're going to feel people's eyes on you too. And then you're going to go to a professional setting. Hopefully it's a convenient place. If it's in summer, this big body will be sweating, will be not in a comfortable state. So I'll be already agitated by the time I get there. If it's too many hurdles to get to that location, yeah, it's
At the University of Sydney, you can't get a park.
well, I've been to this building a few times, but lucky Tim talked me through that. Otherwise, I'd be getting here and quite flummoxed and feeling quite agitated and not knowing how I'm going to contribute to this.
And who sets the timings? And
Well, it's not us really. It's not the
you're
person.
just told to come to that.
Yeah, you're told to come at this time, and again, like your example, and you may not know that the follow-up is in 3 months or so. There's not really much under.
What sort of information are you given before you attend the meeting? You get all the details of the project and what's about and the protocols and everything like that?
I think in the past, it's been a kind of, you alluded that there may be some solution even with this research, which if we know there's 17 years time between the research being done and some, you know, that's a bit of false advertising, but I don't see that anymore. Sorry, what's your question?
Oh, you know, who controls the
timing.
practicalities of the meeting?
Yeah, well,
And who give, you know, are you provided with all the background information?
so the background information, no. So you got to kind of make decisions on the fly, which is not good, because if you want a meaningful answer and you want that person to be able to think about it and really have a good go at the actual answer there.
And when they're discussing things about the project, what sort of language are they using? What sort of
Clinical language is, you know, it's good in the clinic, but outside the clinic, it can be pretty like super morbidly obese, all those terms of obesity and stuff. We know it's a real thing, but to talk about that when you don't need to, probably I think that can be avoided. Yeah.
what about you know, situations and wording and descriptions that might be offensive or in some way trigger issues?
Yeah, so
obviously there's a lot of in anyone with chronic diseases, and particularly somebody living with obesity, there's a lot of trauma involved in their life during that period of managing that condition.
Yeah, so you have to be aware that there are certain triggers for people. Maybe a lot of that trauma, it hasn't been dealt with. You know, you may have people come to these working on your projects who have some level of recovery, and others who in the midst of that suffering. So that's two different types of people there. And I think it's good to have that mixture, but you have to be aware that your words and, you know, your empathy and being genuine, maybe show a bit of your own vulnerability too. That helps. I think that's important. And I think it's important too, to have a group of people that do feel empowered, that they feel they can actually give you proper feedback and actually think about it, because without it, if you're one person by themselves, it's yeah. there is a power imbalance still there, even if it's just perceived.
Got some time for some quick questions.
Yeah, let's, I think we've got a few minutes. I'll hand over to Juliet for that. Thanks very much, Tim and Andrew.
Thank you so much, both of you, and Andrew, thank you. I was suddenly aware that, you know, sort of you're here as the lived experience person, and these are sort of the researchers. And I think that I wanted to first of all thank you for coming, putting yourself, and also recognise we all have various lived experiences, vulnerabilities that, you know, we don't sort of recognise and put out there. And yeah, so just, I have so many questions for Tim and for you, but I will, because of the limited time, put it out to everybody. Louise.
Thank you, Louise Farr from University of Sydney Kids Hospital Westmead. Thank you to both Tim and to Andrew. I always learn so much when I hear you guys speak. There is a challenge, Tim, isn't it? Because we may want to really engage people with lived experience and to actually do it right from the word go, but that requires some form of resourcing that happens before you can actually, there needs to be a promise of future money. I was wondering if either of you, Tim, you may have some ideas too about how that can be enabled. How can we, what are some strategies to enable that sort of initial true engagement, and so that you can write the grant for the funding with the people with lived experience, etc.
Well, there are other institutions such as Emory that actually have a fund for researchers to engage with people. They also have a structure, to have an officer whose responsibility is to enable researchers to better engage with community and consumers. But the other thing that Andrew and I have been working on is developing a structure that deals with some of these issues and enables better consumer and community engagement from the lived experience perspective, so that we have a mechanism that researchers can go to rather than having to seek out representatives themselves and to go through the process. So they'll understand the process. There'll be a mechanism that will give them access to people with lived experience or other stakeholders to address the questions that they might want to ask them. There'll be a formal way of doing it. There'll be the recompense sort of all built in. So everything is there to make it easier for researchers to access the lived experience voice, but more importantly, for the lived experience voice to be appropriate, considered, delivered in a safe environment, supportive environment with a whole lot of other features. And that's what I was actually hoping to talk about today. But we're, like most things, when you're dealing with consultation, community consultation, it takes a lot longer than you expect. So we're not talking about individual projects here, we're talking about research programs and how better to engage people over that period.
I have a question. To what do you see the role to be of social sciences as a lens for this engagement? Is that kind of what you're referring to, or is it a separate level of engagement?
Well, I mean, you're obviously very big on transdisciplinary research, David, and I think obviously we all accept that social sciences do this a lot better because that's the nature of their work. They're more interested in how the community is involved in these issues. So you're right, we could be more effective and engage better by actually working with social sciences on joint aspects of a project, because they're obviously much better at defining the questions, getting engagement with the community, doing that sort of background research, which enables a better consultation, a more meaningful consultation before we even start thinking about how we're going to design and work through and develop that research. But that doesn't sort of mean that as biomedical researchers that we hand responsibility over to others, because there are the other stages of the research process where we need to be focused on what we can, how we can better engage to improve our research and the implementation of it, the recruitment, the dissemination and things like that.
Thank you. Arthur has a question. Before I do, I just wanted to ask Andrew, do you have any questions or things you wanted to put to us, just in case? And you can also think about it while Arthur asks.
No, but I would like to make a comment, like using lived experience people to help. I know we're a tricky cohort to work with. There's a lot going on, very busy, but maybe even using lived experience to help scope out what you're working on too. That can be helpful because you have your academic and also practical knowledge. But if you use lived experience people to also help direct where you might go in the early stages rather than when it's too late, like I won't say which study, but a year after this study started, they're bringing in lived experience people. And I understand, I do get it, I do understand that, but again, I don't. So you should be thinking about that a bit earlier, at least some involvement to help work out where you're going with that. I think that's underrated. People don't underrate that. I know anyway, I did want to make that comment.
Tim and Andrew, thank you very much for your presentations today. I think we've all learnt what's possible, and also we can also appreciate many of the problems that pre-existed and no doubt still exist, and we can start to see why the problem of closing the gap in Indigenous health perhaps has been so difficult, because we haven't been engaging with the stakeholders and the communities in a way that perhaps could have been more productive. Playing devil's advocate for a moment, what can you give, either of you give us, or both, give us some examples of wins that have resulted from taking this approach? We're all time poor and we're all resource poor, and the notion of spending more time and more money in this area necessarily, I think, makes us pause for those of us who are not currently engaged, because we can see that it's more work and it's more effort to garner those resources.
Yeah, well, I did have a few case studies there that did highlight those things. I did race through them and didn't focus on them. It's evident in disadvantaged communities. As you've already pointed out, in First Nations communities and disadvantaged, socioeconomically disadvantaged communities, that the biggest immediate return is actually in recruitment and retention. So that Indigenous community project I showed you, they had 95% retention through the 3-year project. Now that's amazing, but that's 20 years of engagement probably, and that's no exaggeration. They've been working with these leaders and this community and to get their trust, get their understanding, that sort of thing. But even in the Western Australia, I can't remember the university it is, the clinical trial, same thing, is that generally you get, I don't know, Louise, probably 20% of participants in trials, males, in weight loss trials, males, usually dominated by females, about 80%. In this occasion, they got up to 40% males. Not perfect, but double what normally happens. And that's really important, because then they've got much more meaningful results in terms of how these drugs interact on a gender basis. And gender has a profound effect on body weight issues. So there's those sort of immediate returns, but longer term, you've got research which is actually more relevant, more appropriate, addresses issues which are actually more likely to result in improvements in terms of the health status of the community.
I just mentioned a quick one. So we're working on something at the moment. I won't go into much detail, but it's scripting for clinicians dealing with people with obesity, and where traditionally that is a huge point of fear. For somebody going to a GP, to an obesity specialist, to anyone in the medical field, it's fraught with fear and people not coming back to their appointments, just forgetting about getting treatment. For decades, things getting worse. it's something we've worked recently on with not much of a budget at all. The scripts that we're developing for this, for the interactions, will, if even part of them are implemented, will make a huge difference to people having these very fearful interactions with clinicians that are totally unnecessary. So even though we're not quite there yet, we are headed towards that path now.
So scripts
Very
means wording for how to raise weight. Yeah.
Loosely saying scripts, but just giving people approaches on how to have those discussions. So that in itself will make a big difference. Not finished yet. I realise we are finished as well.
Yeah, we don't want to miss our lunch. Just to remind everybody, we have a light lunch out in the kitchen area immediately afterwards. And before that, I'd like you to join me in thanking firstly Juliet for co-chairing.